Okay, thanks.
Yeah.
I'm Angela Webster. I'm Professor of Clinical Epidemiology at the University of Sydney and Director of Evidence Integration at the NHREC Clinical Trials Centre at the University of Sydney too. So I'm talking to you today about HSANDA, the Health Studies Australian National Data Asset. Can you see my slides okay? I can no longer see you, so I presume you're all right.
Yes, we can see.
Okay, good.
No.
Thank you. And the node that we lead here, and I'll explain what the node means in a second. So just to note that I'm talking to you from Gadigal and Wangal land, and always was, always will be Aboriginal land. So this is the structure of my brief talk today. I want to talk about the benefits of data sharing, a couple of case studies of places where my team have used data because we operate in a data integration environment. A bit about the HSANDA Sydney node, the ethics-related challenges that we faced, and some future considerations on how we can improve things. So what's data sharing? Data sharing is about the on-use of data that already exists. So it's about maximizing value from data that already has been collected before you collect new. Some of the benefits are that you can increase dissemination of research by using the data again, making it more recognizable and visible than it was with its initial publications if it was a trial. Think mainly about trials if the trial was published. It means that the research lives longer, it lives on and can contribute more than its initial time frame of when it was recorded or collected in the trial. It means that we meet the responsibilities to share data publicly because almost all of a large proportion of the research done in Australia is funded through the tax dollar, either by the MRFF or through the HMRC. So it means promoting the on-use of data means that the public money is used more than the original purpose. We can facilitate new collaborations, which is particularly important for researchers to reach out and collaborate beyond Australia or within Australia. We can generate new hypotheses and answer new questions that are different from those that the trial may have originally posed when it collected the data. For academics, it means more publications and more citations, including the original data custodians and data team. And by using, we can learn. So by using data and finding creative ways to use it again, we will inevitably develop more guidance and standards around how to access and use data when we share it. Another important thing, I think, and something that me and my team work very hard to do is to reduce research waste and duplication of effort. A lot of the time I see and review for granting bodies studies that will add little to what is already known because we already have data that if it was used more creatively or reanalyzed, we might learn the same thing for cheaper. Although sometimes you can get caught in the timeframes we just heard from the previous speaker. There are some challenges associated with data sharing and for secondary research use that we need to acknowledge and work with and through, including patient privacy. And the return on investment, the public dollar investment in research can be maximized when the data is used to its maximum potential. So how can we use data? So what is the secondary use that HSANDA talks about? Well, the most common is probably in the middle panel here, IPD, so individual patient data systematic reviews, where you bring together data from trials that were all similar or investigating similar questions, and you reanalyze it, thereby revealing through increased power and understanding of heterogeneity, you can find new data, particularly for hard outcomes that occur at low frequency in the original trials, like, some trials measuring death, they may not occur, but when you bring 90 trials together, you might be able to understand something about the intervention on effect on mortality. There's also very important and that underpins all of science is the third panel here, replication and reproducibility. Data checking, revealing fraudulent data, or understanding and reproducing finding is one of the pillars of good science. And the first column here on the left of the screen, secondary projects, is probably my favorite way of reusing data, and that is to ask questions that are beyond and different from the original purpose that the data was collected for. And by that, you can understand the performance of tests or biomarkers, you can understand prognosis, you can use data from trials to understand things through an equity, diversity and inclusion lens by looking at how trials are designed and the impact of dropouts or failures of enrollment or failures to complete the study, and what systems were in place that may have meant that happened. So there's many different ways you can reuse trial data. These are just some case studies from my team. So some examples of individual patient data meta-analysis that we've done just recently. The first one, ICOMP, was published last week in The Lancet with 2 papers there, and that was about umbilical cord management strategies for preterm infants. So it was about how you handle babies after they were born preterm, and whether you immediately cut the umbilical cord, delayed cut the umbilical cord, milk the umbilical cord. And we showed something through the 70 trials of over 10,000 infants there in low, middle income and more developed health system countries that all had the same effect, that delaying cord clamping was best if possible. And with that, we're now working hard with ILCOR, who write international clinical practice guidelines for the world, on how to manage preterm births in all settings. There's also Top Child's another important project we're working on, which is all about deconstructing complex interventions to prevent childhood obesity. And at the moment, we've got 35 trials, but there's about the same again that we're still trying to get. We're working through the process on 30,000 children to try and understand that. And there's a third project we're working on or have published before about managing preeclampsia in pregnant women. So a lot of the reason that this is around perinatal and child health is because the predecessor in my role, that was her specialty. I'm a nephrologist by trade, so I've been learning a lot about babies. And this is some of the more imaginative uses of on-uses data from my trial. We've done a lot of work in the cancer space, looking at biochemical measures and image measures to understand treatment response and to understand prognosis, particularly for priority patient groups. So there's a list of some papers there. But so the gap, we also do some work, methodological work in my team, and what we call meta research, where we do research about research. And we've revealed that there's quite a gap in understanding and implementing data sharing. So we did a study of trialists in Australia and New Zealand, drawn from the Australia New Zealand Clinical Trial Registry, which my team also run, and found that most trialists support the concept of data sharing, but actually when they come down to it, while 77% supported it and 40% intended to share the data from the trial they'd registered in the ANZ-CTR, only 22% were really committed to it. And so even though everyone thinks it's a great idea, not many people do it. And that made us think about what the barriers might be. So to understand that a little bit more, we started to conceptualize the whole of the research life cycle, from funders through ethics, through trial registration, through publication, through post-publication activities. And we looked through, we've got a paper in print at the moment, where we looked through all of the policies and statements made by all of the people globally that we could have access to that fell into one of these pots, to look at how data sharing could be promoted more. And when we got to the national ethics committees that we looked at 124 from different countries around the world, and only 3% of the national ethics committees recommended data sharing. One recommended provided a recommended data sharing statement to be included in the research that it approved, and one specifically recommended sharing COVID-19 data. And I mention that particularly because the pandemic, as we know, was the positive outcome from the pandemic was that it made us all have a look at the processes that we have for doing and generating new research, and stimulated quite a lot of efficiencies that previously had been stagnant. So of these national ethics committees that did promote or appear to recommend data sharing, they were all from high-income countries, none were from the middle-income settings. From another study that we did, we revealed that the main concerns from investigators, from the trialists themselves, were that they didn't want to do anything untoward that would impact patient privacy. They weren't sure how to incorporate data sharing for other causes down the line that they couldn't imagine yet into the informed consent process, and they were very worried that by trying to build in the sharing of data, they may compromise getting ethics in a timely way, getting their ethics proven in a timely way. So those are the barriers perceived by the trialists. So what are we doing to reduce research waste? Well, my team's providing guidance to other researchers on how to integrate IPD analyses and protective meta-analyses into their trials by design. We've developed some resources on how to do things like prospective meta-analysis, and we're also working closely with within the HASANDA initiative to try and promote data on use. I'll tell you a bit about that now. So what is HASANDA? Well, it stands for Health Studies Australian National Data Asset. It's run by the ARDC, the Australian Research Data Commons, for NCRIS, the National Collaborative Research Infrastructure Strategy. So I like to think of NCRIS as being the great-grandmother, ARDC is the grandmother, HASANDA is the mother, and then I'll show you the baby in a minute. The HASANDA has created a network of what they call nodes from around the country of cross-disciplinary specialties. Some are disease content area focused, some are geographically placed, and they're all working together to provide and to co-design and build and provide data for infrastructure to facilitate the on-use and the sharing of data. So the node that I coordinate is known by its nickname as the Sydney node, but really originally it was the Sydney Health Partners node led by the NHRC Clinical Trials Centre at the University of Sydney. So you can see why we shorten it. And on the left here is the list of the original partners I brought together to try and pitch to become a node for the HASANDA process. So it's a number of people across Sydney Health Partners, LHDs, and the University of Sydney who run and do a lot of trials. A lot of primary research and trials that we brought together to try and create a platform for sharing the trial metadata. So HASANDA itself at the ARDC has got some program level projects which are led by them and coordinated by the ARDC, including building the infrastructure, which is the metadata catalogue, which I'll show you, enhancing the ANZ-CTR, the trial registry, to try and be able to lift the metadata directly from the ANZ-CTR entry, so therefore reducing extra work for trialists. They're doing some work with CTIQ around the ethics and consent and resources processes, although that's at an early stage still. There's a consumer engagement framework, there's a data governance framework, there's some scenarios and some community connect projects where we're trying to use illustrative case studies about how this could work, awareness raising and changing, and a business model for sustainability. The projects that we're doing in our node are a bit different. We've built IT infrastructure through the REDCap platform and built a data access request system. We've created standard operating procedures to create research outputs and generate trial metadata such that we can then put trial data into the metadata catalogue. We've developed data sharing agreements and policies to try and smooth that part, which can take a very long time when you're doing IPD programs. We're also doing what we can to communicate and get engagement on this, which is why I'm here today. So how does it work? Well, the primary researchers, the trialists who have the data custodians, collate their trial metadata, which is research outputs, study protocols, data dictionaries, data governance policies and procedures, but not the individual patient data. That's very important. And they list it on the HASANDA's data catalogue, which is called Health Data Australia. And then secondary researchers, who are the people who want to on-use the data, can access and search that. They can discover the data through that, accessing the metadata catalogue. And if they want to, they can then approach data custodians directly to ask for, facilitated through the HASANDA platform, to ask for access to the data. If the primary researchers consider that that's a worthy request, then they can seek ethical consent from the HREC that oversees the original data, and the secondary researcher will seek their own ethics for raising the request to access the data. And if the request is granted and that all goes ahead, only then will the data be shared. So the current ethics-related recommendations that we have in our node is that data providers should seek ethics approval and participant consent for secondary use when they start a study. So that's for studies that are starting now. And if ethics approval was not originally obtained in a trial that's already in progress or has been completed, the ethics committees may be willing to provide access to the data for on-use on a case-by-case basis when they consider the request. The ethics request, what we've had to talk to trialists a lot about, is that the ethics request can be sought after a decision has been made about whether the data request is worthy and the data custodians want to share. You don't need to sort out the ethics before you've decided that you actually want to do it. And we've also suggested some wording that the trial registrants at the time of trial registration in the NZCTR can use to help secondary users understand under what terms the data will be shared. And the words we use at the moment are: consent to provide IPD has not been obtained. IPD may be shared if specific secondary research proposal receives a waiver of consent from our ethics committee. So Health Data Australia is the baby of the Hasanda metadata platform. It's the Hasanda metadata platform. And it looks like this. First of all, it's all about discovery and findability of data that's already there, and it's metadata only. So this is the kind of landing page on the right here of the screen. And just reminding you what trial metadata is: it's information about the data. It's not the data itself. It might be the title, the creator, the year, the research area, the license info, the study protocol, the data dictionary, any published research output that arose from that data, but it's not the data set, and it's not any protected or sensitive information. So far, we've included 117 trials, but more are being added literally daily. This is what you see when you go in. You can, as a trialist, you can decide whether or not you've got ethics approval. You can upload your file. You can declare whether or not there's vulnerable populations that might need special consideration, and anything else, any other information. And you can move across the tabs at the top here as well. So challenges and future considerations about this. The ethical related challenges that we've had raised by the data providers, so that's the primary researchers, the people who did the trial in the first place, is they're not willing to share their clinical trials metadata before HREC approval. So we've been working hard to say the metadata is not protected, there's nothing private about it, it's just data about your trial. They're unsure, very unsure about the process they would need to use to get permission for secondary use. This is for trials that are already completed or in progress. So that needs to be made much clearer. They're very concerned about the data destruction policy. In my view, a lot of the data destruction policies and agreements in ethics approval kind of date back to the days when we had filing cabinets full of paper. Well, we don't now, everything's digital. And they're concerned that how could they adhere to their ethics approvals and share data beyond the 7 years or 10 years or whatever day they were asked originally, committed to destroying their data. And again, the NHMRC needs to do a bit of catch up here. Although they do say now that retaining research data for 15 years or more may be necessary for trials, and that I think is helpful because it shows that there's things you can do with the data that you may not have thought of at the time you collected the data. And I mean, our view that we've come to is that de-identified electronic research, electronic data that's captured should not be destroyed and could be safely kept without providing an ethical risk. So really, this is all about using data to its maximal potential and allowing things to be done that you haven't thought of or didn't know about or couldn't be done when the data was being collected for whatever cause that might be. And I hope that's been helpful. And I just ask for any questions. Now I'm going to come out of here so I can see you because I can't see myself.
All right. That was a really, really interesting talk. And it makes a lot of sense because in every other part of research, for example, you do sequencing, microarray, RNA-seq, protein crystallography, they're all data sets. I mean, domains available for you to obtain the data. So you have to put it in. So in terms of health and human type research, it shouldn't be wasted at the end of the life cycle, deleted. It just seems like such a waste, all the effort put into it. All right, so we do have a few questions. Let me just, where did my chat thing go? Okay, here we go. So Laura actually just pointed out that there's SURE, Secure Unified Research Environment. It's a secure and powerful platform for the sharing and analysis of sensitive health and other data. So
yeah, there's lots of things like SURE. There's also the READ and a number of other ones, but they are the infrastructure to actually actively share the IPD. They're not the infrastructure to make the data discoverable or findable. There's also some other platforms to help discover cohort data or registry or clinical quality trial registry data through the PHRN network, but that's a bit different too. This is about sharing the metadata from trials.
Yes. So Susan mentioned great initiative needs a lot of cultural change at the frontline level to also incorporate local data sets that inform local health questions. And basically she asked, who is the data custodian of a non-commercial investigator-initiated trial or study in a public hospital?
Oh, well, that's most of the trials I deal with, actually. So usually the data custodian is whoever was the PI on the original trial, and they usually have a trial committee. So it's usually not just one person, although we find one person to liaise with when we're accessing the metadata or facilitating the metadata upload. But usually there'll be a trial committee in the way that you normally would run a trial. It would be reconvening that, but usually the buck would stop with the PI or the CIA of the original funding arrangement.
And I think we have time for one last question. So Evan says, I suspect that data sharing proceeds much more smoothly once the various parties become familiar with the others, with whom they will be doing the sharing, as distinct from anonymous entities. Has this been assessed?
Well, I mean, one of the reasons that Sander wanted to build this infrastructure was to facilitate a common pathway and a common way of approaching and discovering and approaching people if you have an idea about data on use that you want to try and access the data for. So whether it's easier to share things with people you know, that's usually the case. But the idea of the Sander platform is to kind of facilitate that collaboration, that communication by making the pathway clear. So secondary researchers, the people who want to use the data, know how to approach, and it can be kind of standardized in some way so that it's a bit more equitable, it's a bit more a level playing field.
Okay, awesome. Thank you so much, Angela.